All right, everyone, welcome back. Now we're going to move on to our complex cases. These are even more fun than the first retina section and the glaucoma section. And we're going to start with a pretty cool case that not only involves the retina, but also has findings in the optic nerve.
So this first case is an 83-year-old female, and she was coming into the glaucoma clinic at the school just for a follow-up on primary open-angle glaucoma. Of note, her medical history is remarkable for type 2 diabetes as well as hypertension. And so on the clinical examination, I had picked up that there were some abnormal sort of fine stringy blood vessels in the superior nasal peripapillary region. And, given that she had type 2 diabetes, my concern is this potentially neovascularization on the disc? Because you can see patients with proliferative diabetic retinopathy that we sort of call like featureless retina that can have just very few or very minimal background diabetic retinopathy findings like dot blot hemorrhages, etc. So I wanted to do my due diligence and make sure that this patient didn't have neo of the disc and proliferative diabetic retinopathy in this particular case. As part of this glaucoma assessment or follow-up, we did a nerve fiber layer OCT. And what else was interesting on this particular scan, so she certainly has some glaucomatous nerve fiber layer loss, but there's a little section of superior nasal nerve fiber layer loss. And we can see it also on this asymmetry in the Tisnet curve down here, in the left eye that corresponds to the same location as the abnormal vessels. And superior nasal isn't a very common location where we would expect to see glaucomatous nerve fiber layer loss. So obviously wanted to investigate this further and to visualize whether these vessels were on top of the retina or in the retina. I decided to do an OCT angiography scan. And so here's a 6mm OCT angiography where we're going through the superior nasal sort of portion of the posterior pole, as well as that superior nasal peripapillary region. And this is the superficial capillary preset. We can see there's some retinal telangiectasias, as well as some areas of retinal capillary dropout, really more suggestive of a branch retinal vein occlusion. And I took my slice navigator to cross-section through that area of abnormal fine blood vessels that I suspected were neo on the disc. And you can see on cross-section that those vessels are definitely intraretinally located and are likely collateral vessels versus neo on the disc we would expect to be pre-retinal neo, so it would be up on top of the retina. So I'm able to confirm this is not neo of the disc, this is not proliferative diabetic retinopathy, but a patient that's had a superior nasal branch retinal vein occlusion related to presumably hypertension and hypertensive retinopathy. And I think looking back now at the magnified color fundus photography, we can see some other features of branch retinal vein occlusion, those like subtle telangiectasias, as well as like a few small, maybe dot blot hemorrhages present there. But it could have been hard, to determine whether that was diabetic retinopathy versus a vein occlusion. And really the value of OCT angiography in making the diagnosis in this case. And we know that there's a close association between glaucoma and retinal vein occlusions, especially central retinal vein occlusions.
I'm gonna say, what a incredible pickup. This
Yeah.
is such a subtle finding, and it would be so easy to overlook this. Eric, in the setting of a chronic RVO, you effectively lose all of the hemorrhages that we see in the setting of an acute retinal vein occlusion, and it becomes this really bland fundus. Uh, first of all, I love the fact that you used OCTA, but Eric, in your practice, is this something where maybe the role of FA is diminished and you're really just trying to get OCTA imaging over this?
Yeah, great question, Yasha. I think in this situation when there's a relatively mild finding, I don't think intervention is probably going to be necessary. I think OCTA is perfect, right? In this case, it's non-invasive, it's quick. I don't have to subject the patient to an invasive needle stick. I still find that the fluorescein angiogram could be helpful in vein occlusions, particularly ones that I think have active exudation. I want to see the extent of leakage, and I think there's still a benefit to it in that role. But I certainly find myself using OCTA more and more in lieu of FA.
Yeah, that's such an amazing case. And, it's also important to realize that once you have this RVO, you'll actually see a focal area of thinning of the optic nerve. And sometimes you can easily make the judgment, hey, the glaucoma has progressed. But in reality, if you didn't identify this, you wouldn't realize that there was an RVO that was contributory to the progression of the nerve fiber layer loss. So, with that said, I actually kind of want to move on to another case. This is a 37-year-old hemophiliac who presents for a routine eye exam. Vision's 20/20, ocular exam's normal. They actually thought I was a general ophthalmologist, so they just showed up in my clinic. And this is the OCT that I get. When patients show up in my clinic, essentially everybody gets an OCT in the retina clinic. But just take a look here, and I want you to ask yourself, what's the diagnosis? Because you can actually make it just on that OCT alone. So I'm going to highlight a clue, and that is when you look at the macular cube, you see this area of nasal thinning in the right eye and temporal thinning in the left eye. So then you have to ask yourself, what layer is involved? So look at the cross-sectional OCT, and when you look, especially in the right eye, we would ideally like to see a really healthy GCIPL, which we don't see. And temporally in the other eye, we don't see that. So I sent this patient back and I got a ganglion cell analysis. Now, remember, when we get the ganglion cell analysis, what you're really doing is you're looking at the ganglion cell plus IPL layer thickness. And here, when we isolate out that one specific layer, we can really highlight this homonymous deficit where we get thinning of the nasal macula in the right eye and the temporal macula in the left eye. So what's this diagnosis? Well, this is a case of a patient who has not only hemophilia, but also HIV and presented at 1.5 years of age with a brain bleed requiring surgery. Unfortunately, he also received blood transfusions, which is ultimately how he ended up contracting HIV. But what we see is a very dense right homonymous hemianopia. And so this was able to be picked up on the macular cube, and specifically the GCIPL. So the diagnosis here is retrograde transsynaptic degeneration. And it's a really, really cool way where you can identify a pretty significant neurologic deficit by OCT alone. So the way this works is, remember, going back to your basic physiology, we have at the retinal level in the retinal ganglion cell, this goes back through the optic nerve synapses in the lateral geniculate nucleus. And then there goes back through the optic radiations all the way to the visual cortex where it synapses again. So if you injure yourself at the retinal ganglion cell layer, for instance, glaucoma, you can see changes going back all the way to the visual cortex. That would be anterior grade transsynaptic degeneration. And it's one of the reasons why glaucoma researchers are sometimes looking at MRIs to look at the brain. Conversely, you can injure any part of the brain, and through retrograde transsynaptic degeneration, that effect goes all the way back to the retinal ganglion cells, and we can pick that up on our nerve fiber layer analysis and our ganglion cell IPL layer analysis. And I specifically say both because the nerve fiber layer would be totally normal, and I'll show a case of that. So this was first described in the early 20th century, where injury to the fetus really sort of highlighted the fact that maybe there was this critical period that resulted in it. But then we started to realize, as our imaging got more sophisticated, that even in adults with brain lesions, we can identify this. So here's a patient with a meningioma in the right occipital lobe. And notice that if you just got a nerve fiber layer analysis, you would completely miss this diagnosis. So you really have to get the GCIPL if you're suspecting that homonymous pattern of thinning that we saw on the macular cube. So I'm going to just pause there. Carolyn, I know you have a ton of these cases, and can you identify when you look at the macular cube where this localizes in the brain?
Yeah, I think like with the case that you had there, where there's almost like a vertical respect to the GCC loss and it's on the same side, so a homonymous GCC loss, you can at least generalize that it's retrochiasmal, right? So I think it's really interesting. I have patients with pituitary adenoma compression of the optic chiasm where they present with binasal GCC thinning also sort of has this like vertical respect to the GCC loss as well. So I think it's so underutilized. That is like GCC imaging in neuro-ophthalmic disease. Like we're so used to trying to pick up early glaucoma with it, but it mirrors the visual field defects in neuro so well.
Yeah, really, really does. So obviously just kind of a cool case. And if you identify it, you're just going to feel like a total all-star.
Yeah, and I
So
love on this image that you showed right here, like even in the nerve fiber layer, how you have some of that temporal loss on the left eye. I think that's another red flag that, when we have this horizontal NFL loss, that it's likely something going on at the chiasm or behind and not something like glaucoma. Because I think there's a lot of patients misdiagnosed having glaucoma that actually have, say, like retrograde ganglion cell loss.
yeah, yeah, absolutely. I think so. With that said, let's keep it going, and we're going to move on to Eric, who's going to present another really interesting retina case.
Those were two very interesting cases, which I think nicely integrated our glaucoma and retina focus here. Unfortunately, I'm going to turn just to retina here, and we'll look at a case of vitelliform maculopathy in a patient with pseudoxanthoma elasticum and angioid streaks. And I think there's an image here that really changes everything in making this diagnosis and in particular important management decisions. So this is a patient who presented to me at 52 years old and was referred for ongoing management of choroidal neovascularization in both eyes. He had a past medical history significant for pseudoxanthoma elasticum as well as hypertension and hyperlipidemia. He had been referred from a outside practice. He had moved to the area after receiving 5 intravitreal bevacizumab injections in both eyes, and the notes indicated that he had what they characterize as refractory CNVs in both eyes. His visual acuity was 20/40 in the right eye and 20/50 in the left. His intraocular pressure and anterior segment examination were relatively unremarkable. If you look at this color fundus photographs here, you see an interesting appearance of the central macula. You see this dependent vitelliform lesion, vitelliform material present in both maculas with some corresponding RPE changes. This is the structural OCT cube. We're going to look at these run through because it's really important to see the entire cube. So at the superior aspect of this vitelliform lesion, you see that it's hyporeflective. But as you get to the bottom of the lesion, we see this hyperreflective vitelliform lesion material pooling. And this is the classic pseudohypopyon appearance that we see in best vitelliform macular dystrophy. I actually want to go back and point out in this case, however, this is not best, but what we see in this case is circumpapillary angioid streaks with radiations extending into the parafoveal. I'm gonna start over from the photograph because I forgot to mention the angioid streaks, which is really key. I apologize. And go. If we look at the color fundus photographs, we see these very interesting appearing vitelliform lesions with dependent vitelliform debris present inferiorly in both maculas with some associated RPE changes. I also want to highlight these circumpapillary angioid streaks with radiations extending from the nerve. If we look at the structural OCT cubes, we can see, and we'll run these through, you have a hyporeflective cavity present at the superior aspect of this vitelliform lesion and the hyperreflective vitelliform material in that dependent position. This is the classic pseudohypopyon appearance that we frequently see in best vitelliform macular dystrophy. I did get an FA in this patient as it was somewhat unclear whether there was truly a CNV present despite the prior treatment at the outside practice. And you see this FA is not particularly informative. We see some blocking, actually, which is interesting, from the vitelliform material in both eyes, as well as hyperfluorescence corresponding to the areas of the angioid streaks. The image that changed everything in this case is the OCT angiogram. This is a relatively old case, and so this is a Cirrus 5000 OCTA, and it's the ORCC slab. And we see a very clear CNV present here in the right eye, in the infranasal aspect of the macula, and that corresponds to this area of increased flow on the cross-sectional image with flow overlay at the bottom. However, in the left eye, we see no corresponding CNV present on the en-face image. And if you scroll through the entire cross-sectional portion with the flow overlay, we saw no evidence of abnormal flow in the outer retina either. Having said that, I gave this patient the option of continuing to treat the right eye only or treating both eyes. This patient felt very strongly that his prior provider was on the right track and had great confidence in him. So he ultimately elected to continue to treat both eyes. And this is where I think we see the power and the accuracy of OCTA. And so this is after 3 monthly bevacizumab injections under my care. And you see over that time frame in the right eye, we see a significant reduction in the thickness of the retina in that superior hyporeflective area in the right eye. However, in the left eye, we see no change. Just to drive this point home, this patient was luckily, at least for my case, lost to follow-up for 4 months. And so they had no treatment, and we see a corresponding increase in that area superiorly in the vitelliform lesion in the right eye, corresponding to increased exudative subretinal fluid. However, without treatment for 4 months in the left eye, we see no change. Obviously, I elected to restart treatment in that right eye only, and we see after a single bevacizumab injection, this is a 6-week interval, we see again a nice reduction in the extent of exudative subretinal fluid. And by our challenge, de-challenge, re-challenge paradigm, we can, I think, confidently say this patient has a CNV and confirms the OCTA finding. Whereas in the left eye, again, without treatment over 6 weeks, no change. So if we use our challenge, de-challenge, re-challenge paradigm, we could confidently say there's no CNV. And it's nice that this really kind of confirms what we're seeing on OCTA. I think for many folks who aren't as familiar with using OCTA angiography, they sometimes don't trust their findings. And I think seeing cases like this really drive home the point how accurate this technology is. This obviously seems like somewhat of a zebra, but these patients do exist. This is actually a recent publication from Retina, which is actually online in preprint. And this is a case series of 14 patients, 23 eyes with angioid streaks and vitelliform maculopathy. And wanted to highlight that 25% of these patients, or 26 in this case, had a CNV present, although it's incredibly difficult to make this diagnosis because these patients have this area of hyporeflective sort of degenerating cavity, which can be very difficult to distinguish from exudative subretinal fluid. So just wanted to highlight some take-home points, why OCTA can be invaluable in evaluating vitelliform lesions, not only in this condition, I think, but also acquired vitelliform lesions in macular degeneration. As I mentioned, the degenerating vitelliform material, as it kind of goes away, it leaves this kind of cleft or empty space, which can be relatively indistinguishable from exudative subretinal fluid. I think particularly if you only have a single or limited time points, it's dome-shaped. It's obviously hyporeflective. I think FA in these patients can oftentimes be equivocal because the CNV or leakage can be obscured either by blockage from the vitelliform material or heavy staining of the vitelliform material. These patients certainly need close monitoring if you elect not to treat them, as it can be, as I said, challenging to definitively ascertain whether CNV is present.
Really tough case. I think these are sometimes like some of the hardest cases to really identify what is the appropriate strategy. And sometimes, even like the way you started that case off, sometimes you just have to try, right? And then, eventually your imaging technology will catch up, as it did in this case, to really highlight the fact that you had choroidal neovascularization in the right eye, but not in the left eye. So Carolyn, a quick question. In this case, you saw all these pigmentary changes, but it wasn't abundantly obvious to me that we had angioid streaks until I saw the FA. What imaging do you typically use to identify angioid streaks if you're suspecting it?
Yeah, I think a lot of optometrists don't have access to FA, and so fundus autofluorescence or FAF imaging is a great alternative. I love doing it in any sort of outer retinal disease like macular degeneration, pachychoroid spectrum disease, and detect angioid streaks. It's really valuable not only to highlight and better visualize the streaks themselves that radiate from the optic nerve head, but to sometimes also identify like superficial dystrusin that's commonly present in patients with angioid streaks as well.
Yeah, absolutely. And I'm sort of taking some lessons back from Carolyn and the simple talk, and that is that there was this subtle double layer sign in the right eye as you were sort of scrolling through the cube, Eric, in that right eye. And I think when you sort of see that, I love the fact that you show OCTA images over that, because that's really where you had this sort of eccentric choroidal neovascularization away from the vitelliform lesion. So just a quick sort of lesson to the listeners. Eric, maybe can you talk to us through when you're examining somebody, are you going through the entirety of the cube and then are you going back and getting OCTA, or is that just sort of like a default strategy?
Yeah, to be honest, I'm using obtaining OCTA in most of my patients who I think have a potential either outer retinal exudative disease or retinal vascular disease. I think that it's incredibly valuable, and I think that I'm oftentimes learning more, and that it's sort of augmenting my structural OCT analysis. I do want to make a point about when you look at OCTA. I think one of the things that I struggle with, particularly when you're looking in the outer retina and RPE areas, you oftentimes have to manipulate the slabs a little bit to get the best image, right? And I think that's one thing that people don't love to do because we're all very busy and it takes time. But I think to get your best images, particularly if there's you have a high suspicion, but you're not seeing exactly what you expect to see on the en-face image, I do find that playing with the borders of the slab can be incredibly valuable for looking, particularly for occult or type 1 lesions.
Yeah, awesome. Absolutely great lessons. And we're going to turn it back over to Carolyn for one last case in the retina section, that is.
So I've entitled this last retina case, Acute Onset Metamorphopsia. This was actually a 38-year-old female, a primary care physician that's one floor up from us in our IHS hospital facility. So she's like a VIP patient. She's coming down, just dropping in optometry and saying, I've noticed some new onset floaters and slightly distorted vision in the left eye for the past 3 days. This is her initial examination with us, so a new patient. We hadn't seen her before. But she told us she had LASIK surgery back in 2010. And at the time of that surgical examination, they said she had some old scars in the back of her eyes, but she wasn't sure what they were from. With regards to her medical history, it's unremarkable. Her vision in the left eye, where she's noting this metamorphopsia, is slightly reduced to 20/25 plus 2. And as we can see in the macular color from this photography here, she has a round hypopigmented lesion in the superior temporal aspect of the macula. And I think what's important to note about this is that the margins of this round lesion are kind of like fuzzy, versus if this was just like an area of RPE dropout, we would expect, or like a window defect, we would expect the margins to be far more distinct if we think about something, let's say, like geographic atrophy. Whereas here, the borders are fuzzy, especially on this like more nasal aspect of this lesion. It almost has this opacity or kind of grayish hue, greenish kind of hue to it. I took some structural OCT raster scans through this particular lesion as well as the center of the fovea. You can see the center of the fovea here looks good, it's unaffected. But when we look at the region of this hypopigmented circle, there appears to be a disruption in the RPE Brooks membrane complex that's allowing for some light transmission to come down through the choroid, so choroidal hypertransmission. And then adjacent to that area of disruption, there's some subretinal hyperreflective material or kind of fuzziness. And we see, I think this has been a theme throughout our cases, thickening of tissue, right? So we see thickening of tissue. That really helps confirm this isn't just like a window defect or RPE atrophy. We certainly need to suspect with this thickening, with this subretinal hyperreflective material, with her complaint of acute onset metamorphopsia, that potentially choroidal or subretinal neovascularization is present in this case. So of course, we're going to do OCT angiography. And on OCT angiography, I chose to do a 3mm scan to get really high resolution detail of this neovascular net that I suspected. And you can see even on the 3mm scan how kind of small and fine this neovascular complex is. And this is, again, our outer retina choriocapillaris slab that's ideal for detecting subretinal or choroidal neovascularization. You then have to go and ask yourself, well, this isn't like your grandma's macular degeneration, right? There's something else that's potentially causing this neovascularization in a 38-year-old female. So we run through these differentials. Like we notice she's had LASIK. So could this potentially be myopic degeneration and a lacquer crack that has allowed neovascularization to form? Potentially a choroidal rupture from trauma. Could this be ocular histoplasmosis or angioid streaks like Eric just presented? Any past choroiditis or chronic pachychoroid spectrum disease would be kind of on your list of differentials as well. And part of why I really wanted to share this case is how combining like multimodal imaging technologies can really help you clinch the diagnosis. So here on this ultra wide field Claris fundus photography photo, we can see not only does she have this macular choroidal neovascularization or maculopathy, she also has these punched out chorioretinal lesions in the mid-periphery. Although the peripapillary atrophy is really subtle in this particular case, she seems to have the features of the classic triad of presumed ocular histoplasmosis syndrome. Here in the left eye, this is the ultra-wide field Claris color fundus photography. She had some of these punched out chorioretinal lesions as well, but the macula was void of any sort of chorioretinal atrophy or neovascularization. So we referred her to retina. She ended up getting anti-VEGF injections in the right eye only. And I think what's great too is we can tell her that the prognosis for her right eye is quite good because there's no macular like atrophy present here.
Carolyn, what a cool case, and I think to even have that insight that this may be an inflammatory neovascularization was incredible. Eric, inflammatory CNV certainly looks different than your classic neovascularization or type 2 neovascularization, which may just present with SHREM. So just for the viewers, any tips on how what should we be looking for to identify that type of inflammatory neovascularization? Do you use OCTA, or does the structural OCT kind of give you enough information to make that judgment?
I think structural OCT, I think is still very helpful. I think as Carolyn showed, you can see this kind of ill-defined hyperreflective lesion in the subretinal space, but these can be quite small. It's interesting that a lot of these patients can be incredibly symptomatic with tiny lesions, right? And so patients will come in and say, there's this horrible thing in my vision, and I look on structural OCT, and it can be challenging to see that, although it can be picked up, I think, with careful analysis. But I think OCTA really highlights that. It really pops on OCTA. So I prefer to use both modalities in conjunction.
Yeah, and the beauty is if you can identify this before it really scars in, just a couple of, or even one or two anti-VEGF injections is maybe all this person needs, because these lesions in particular encapsulate and they can be treated on a PRN basis, unlike our typical macular degeneration or even angioid streak patients. So with that said, we're going to turn it back over to our glaucoma colleague, and we're going to wrap this up with one of my good friends, Shalini Sood, presenting a case.
Hello. So to go along with our theme of glaucoma and retina, I think an area to intersect clinically is our neovascular glaucoma patients, as well as uveitic glaucoma patients, who tend to be some of our most challenging cases. So I just wanted to give a short presentation of a patient that we've been managing with my retina uveitis team, and just get the input of our panel this evening. So I have a 25-year-old white female who presented in the fall of 2020 to the emergency department with a pressure of 50s in the right eye. She had not been under the care of an ophthalmologist for a few years now, and recently had moved from Florida to Ohio. She had a history of JIA, polyarticular, diabetes type 1, and was in her first trimester of pregnancy. She reported a history of cataract removal as a child, had been left aphakic in the right eye, and the patient thought that she had a lens placed in the left eye. Her vision was 20/60 OD and light perception in the left eye, and the wearing refraction was pretty much consistent with that aphakic correction in the right eye and likely IOL placement in the left eye. She currently was on maximal medical therapy with drops and Humira injections. On exam, she had a mostly closed angle with NVA and a vitreous hemorrhage. So we emergently had to take her to the operating room to perform pars plana vitrectomy and an AMA tube shunt that we placed in the posterior chamber of the pars plana, and endo laser. Intraoperatively, the retina surgeon noted a sharp demarcation line with avascular retina. So there was a question of if this patient may have had ROP or fever, though the patient reported not being having a history of prematurity. After the placement of the AMED, her pressure was initially stable throughout her pregnancy, but following pregnancy, her pressure started to creep up. Because she was not nursing, we felt comfortable with starting COSOPT. So the attention was then moved to the left eye, and you can see on this UBM that there is indeed an IOL present, but some very dense opacities that were present anterior to that optic with a 360 angle closure. There was no RD noted on B-scan. There was a pars plana vitrectomy performed for that left eye with removal of that lens that had all those dense opacities anterior to the optic. She was left aphakic. She had significant CME postoperatively, but with the addition of topical prednisolone, there was resolution, and she did correct to 20/30 in that left eye. And you can see basically to the right, all the way to the right is that resolution in the left eye on the OCT, and in the middle is the right eye. You can see the atrophic retina in that eye with some mild intraretinal fluid. Her pressure did increase to the 30s in the right eye on max drops again, and a CPC was performed in that right eye in 2022. This is the first time we were able to get a visual field after she had that lens removed in the left eye, and her vision thankfully was 20/20 in that left eye, 20/80 unfortunately in the right eye. You can see the visual field right eye, just a central island that remains, and the left eye had some circumferential defects. At this point, her pressure was actually well controlled in the teens. Following the most recent procedure in the 2023, some mild subretinal fluid was noted in the left eye, so topical prednisolone was increased with resolution. But she then, of course, developed a steroid response, and her pressure went up into the 40s. She was started on Diamox, and her pressure responded quite nicely. And throughout that year, we went in this back and forth clinical course where her CME would improve when she was put on a more potent steroid like Durezol. Then we would have to put her on methazolamide, oral CAIs. We tried to switch her back, taper off the steroid, and then the inflammation would return. So anytime we tried to taper off the prednisolone or the methazolamide, her pressure would increase and the inflammation would return. So Xipere was then injected twice in 2024 with initially improvement, but then unfortunately by the end of 2024, she had return of the CME, as you can see in the OCT at the bottom, and she was started on oral prednisone at this time, hospitalized with DKA, and she was switched from methotrexate to Remicade. So at this point, my retina colleague decided to refer her to our uveitis team. And this consult happened earlier this year. You can see in these fundus photos that similarly that you'd seen previously that this patient has a cupped out nerve in the right eye, some sclerotic blood vessels, the lasers that was performed a few years prior. And then the left eye actually looks pretty healthy. We've got a very healthy optic disc. And not really those signs of ischemia of PDR that we saw in the right eye. So the working diagnosis at this point was that the ischemia was likely related to the vasculitis because of the asymmetry of PDR that was noted on exam. OCTA, you can see that there is some persistent subretinal fluid in that left eye. And of note, the foveal avascular zone is larger in the right eye than the left eye, but overall, no significant macular ischemia that we can see in either eye. Fluorescein angiogram was also performed at that time, demonstrating petaloid leakage, peripheral vascular leakage, and hyperfluorescence of the optic nerve in the left eye. She had this persistent KP that was noted off and on, but also then a follicular reaction was noted on the conjunctiva. So we decided to stop the bromonidine. She was again back on maximal drops with methazolamide, changed back to Durezol, continued on Remicade, and her pressure was starting to creep up again in the left eye to the mid-20s. But again, her nerve was pretty healthy. I had offered this patient a shunt, noting that she was, relatively young and she had was going to likely need steroid injections or some kind of chronic therapy. But instead, she was refusing that. So we went ahead with micropulse earlier this year. And then the left eye started to have an increase in pressure. And again, this was the eye that had the Ahmed, the pars plana. So we did, now this would be the second CPC diode with a Kenalog injection in the spring of this year. So on most recent examination, just a couple months ago, her vision is 20/60 right eye, 20/20 left eye. Her pressure, thankfully, at this moment is controlled at 5 and 13 with Cosept in the right eye, Brocletan in both eyes. She's been off of oral CAIs since her last CPC several months ago, and she maintains Durezol twice a day, which has kept her CME under control. And of course, the Zypre has also assisted in that as well. So this is an example of one of our patients where we've had the team of uveitis, retina, and glaucoma all working together. And right now, at this moment, it's a win. So thank you for your attention.